Good morning, everyone. After this fantastic educative lecture of in memory of Dr. Dhilakia, I wish to inform you that we are going to have a Veterans Surgeons Forum, which is one of the prestigious lectures besides the Young Surgeon Forum, which was started a few years ago. And none other than Alaric Arujis, who is going to be recipient of that, and he is going to deliver lecture. I would request Professor Alaric Arujis to please come. Your CV, Alaric? Alaric, he has got a huge, long CV, biodata. That will take me half an hour to read. But everybody knows you, so he's going to talk about developing screening guidelines for DDH hip surveillance for a billion plus population. Lessons learned.
Thank you very much, sir. Respected chairpersons, teachers, colleagues and friends, it is my distinct privilege and honor to be selected for the Veteran Surgeons Forum of VIROC this year. I know a number of my contemporaries and seniors sitting here were quite shocked when they heard that I was going to the veteran surgeons category. All I would say is that probably I look older than what I actually am. And there isn't any mid-surgeons forum really in VIROC. Having delivered the Young Surgeons Forum 25 years ago, it's wonderful to come back here. And though I really don't qualify as a veteran, I don't have those pearls of wisdom to drop, I thought I'd share a little bit of what I've been doing over the last couple of years with respect to some amount of preventive medicine. And I'd like to think that today my talk is going to be a bit disruptive because I'm not going to be speaking about a clinical orthopedic topic, but rather I would like to stimulate some of you at least in the audience to come out of your comfort zone and think like a social scientist. I have my teacher in the audience here, Dr. Johari, and this is one of his very favorite quotes. This is one by Thomas Alva Edison, who almost a century ago said that, and prophesied actually, that the future doctors won't just look at the curative aspects of medicine, but actually look more into the preventive aspects. And over the next 15 minutes or so, I hope to share with this august audience some of the efforts we have made to develop preventive screening guidelines for two important pediatric orthopedic conditions, developmental hip dysplasia and hip displacement and cerebral palsy. I know almost all of you are cognizant of the fact that DDH is not a single entity, but rather a spectrum of conditions ranging right from a mild radiographic dysplasia at one end of the spectrum to a complete dislocation at the other end. And while we talk of the incidence of DDH as being 1 in 1,000, we know that clinical hip instability and radiographic dysplasia is far more common in the neonate. I think it's good to consider the incidence of DDH through the lens of common birth defects. And you can see right up from here that it is far more common compared to many of the visually apparent congenital anomalies that we're used to seeing too, like clubfoot. Furthermore, it's not a disease seen only in Western population. In fact, many studies from India have clearly shown that the incidence of DDH is as much, if not more, than what reported in other countries. A frank dislocation should be easily picked up at birth, although most clinical tests are not so sensitive or reliable for the milder grades of dysplasia. While a hip ultrasound can pick up virtually every case of DDH, the availability and expertise in our country is lacking. A hip X-ray is not a good screening tool, we know, in the neonatal age, but is useful after the age of 4 to 6 months. Whatever the diagnosis, it is well proven that early diagnosis and prompt referral will result in good treatment outcomes. If diagnosed before the age of 6 months, we know that DDH can be very successfully treated with a Pavlik harness or a hip spica with a low rate of complications. Unfortunately, due to lack of a screening program and awareness among pediatricians in our country, DDH is so often picked up when the child starts walking and presents with either a limp or a limb discrepancy. The treatment we know is much more complex at this age and requires the services of an expert pediatric orthopedic surgeon. And even then, the treatment is quite complex. It's fraught with a higher rate of complications and puts a huge economic burden on a fragile healthcare system. Coming to cerebral palsy, in fact, the awareness regarding progressive hip displacement in cerebral palsy is even less among most healthcare professionals, even though it's seen in almost a third of patients. Paradoxically, it's difficult to detect, but easy to manage if picked up early and vice versa. You know that children who are bedridden with quadriplegic cerebral palsy are at the highest risk of progressive hip displacement between the ages of 2 and 6 years. And this risk is not related to the motor type, but rather to the gross motor functional status of these children. What are the consequences of hip displacement in CP? I think many of them are not well known. We know that in the walking child, it can cause an inefficient gait, but more so in the child who's non-ambulant can cause severe problems of sitting balance, pressure sores, difficulty in hip abduction resulting in problems with perineal hygiene, and more importantly, overwhelming pain in more than half of these children. Regretfully, it's not uncommon to see hip displacement which is neglected, as in this 10-year-old girl who presented with quadriplegic cerebral palsy and an end-stage severe hip disease on the left side. She has inability to sit, they have difficulty in perineal hygiene. At surgery, you can see that the articular cartilage is completely eroded off, and therefore it necessitated a femoral head excision as a salvage procedure, which don't always give the good results. This is exactly why hip surveillance is absolutely crucial in children with CP. We know that hip displacement in these children is often silent and insidious initially, but can cause severe morbidity if left neglected. Fortunately, early detection permits preventive or reconstructive surgeries to be performed and therefore reduce or eliminate the need for salvage surgeries. I think this is interesting to know. The World Health Organization has actually established 10 important criteria to decide if a particular health condition is worth screening. And fortunately, both of the conditions we are talking about today tick all the boxes in the WHO checklist. So what is the solution? It isn't that things haven't been done. In fact, there are various national and regional hip screening programs in several developed countries and regions of the world where screening is done for both DDH and for CP hip displacement. However, most of these programs and guidelines that have been developed meet the needs of the local healthcare system and are not obviously transferable to every healthcare system, and especially in developing countries like India. We definitely know that wherever these guidelines have been implemented, there's been a marked reduction in the incidence of late presenting DDH and also late displacement of cerebral palsy, and has become the standard of care virtually globally. The American Academy of Orthopedic Surgeons and the American Academy of Pediatrics have established screening guidelines for DDH, and many pediatricians in the US and other developed countries have incorporated hip screening into their clinical practice. Similarly, guidelines for hip displacement in children with CP have been implemented in a few countries with socialized healthcare, like Sweden, Australia, and some provinces of Canada. But how are these guidelines applicable to India? We know that there's a poor awareness of DDH screening and hip surveillance among pediatricians and allied healthcare professionals. We know that ultrasound availability and expertise is available only a few urban centers, and it's tightly restricted because of the very stringent Preconception Prenatal Diagnostic Techniques Act that we have in India. If children get through screening, there's no structured surveillance to detect late cases. And I believe there's very little benefit in teaching early diagnosis if there's no pathway ahead for referral after that initial diagnosis has been made. I don't need to belabor this point to this audience here. We know that India suffers not only from a population explosion and a high birth rate, but from a very chronically underfunded public healthcare system where less than 1.5% of our GDP is allocated to healthcare. And compare and contrast this with other countries of the world. Combined with this lack of infrastructure and a chronic shortage of doctors, especially in the rural areas, this serves as a perfect storm to result in a large variability in the equity and quality of healthcare services provided in our country. It's no surprise, therefore, then, that 50% of the healthcare, even in rural areas, and up to 70% in urban areas, is provided by the private healthcare sector, which is often quite disorganized. To put this into perspective, the numbers are truly staggering. With a conservative estimate of 1 in 1,000 incidents, there are 25,000 children born every year with a dislocated hip. With a 3% prevalence of cerebral palsy and a 35% incidence of hip displacement, more than 500,000 children with CP will present with a painful hip dislocation. How does one then respond to such alarming statistics? I think the result and default panic mode is to bury our heads in the sand, like what we've been doing for many, many years. However, the recent clarion call to develop a self-reliant India, I think, encourages us to take the problems head on and develop innovative local solutions to these issues. Unfortunately, this often takes the form of a quintessential Indian ethos of Jugaad, where we try to find easy, quick fixes using minimal resources for very short-lived gains. We very early and readily acknowledge that quick fixes are not really the best solution for such important systemic issues, and a root cause analysis using a problem-solving approach devised by management gurus was really required. We began this project by performing a quick survey of orthopedic surgeons, pediatricians, and allied healthcare specialists to determine a potential support for developing India-specific hip guidelines and to identify the knowledge gaps and potential obstacles to implementation. The results were quite revealing. We found that most of the respondents agreed that hip displacement is a problem, but only half of these respondents were actually using the existing hip surveillance guidelines. There was a huge groundswell of support to say that if Indian guidelines were indeed developed, 100% of respondents were happy to adopt and implement them. And the common barriers that we felt to implementation were what was well known. There was a poor awareness among healthcare providers about both these conditions. So armed with this encouraging inputs, we decided to collaborate with 12 national organizations that have an interest in diagnosing, referring, or treating children with these two conditions, and therefore decided to jointly develop a care pathway that would ensure early detection and prompt referral. The Pediatric Orthopedic Society of India and the Indian Academy of Pediatrics led this joint initiative with technical support and funding from our international collaborators from Canada. Formal collaborations were established with key members from all of these 12 organizations, which roughly represent about 150,000 healthcare workers in India, speaking to the potential reach of these guidelines once implemented. Just as we were about to roll out this ambitious national project in March 2020, an ultra-microscopic, barely living organism began to wreak havoc all around the world. And as the number of COVID cases began to rise exponentially and our earnings dropped precipitously, we knew we had to pivot in order to keep this project alive. Realizing that every problem is just actually an opportunity in disguise, we used the slack time that we had in clinical practice to move rapidly from a survival mode to acceptance, and then to a remarkable phase of resilience and strength to get the job done. We used a well-established scientific model based upon these 4 pillars of creating awareness, generating the evidence from literature, developing consensus where evidence was lacking, and finally working on the implementation strategies. We used a 3-phased approach, which was designed consisting of a preparatory phase, a consensus building phase, and finally the guidelines writing phase. And I will go through each of this in some detail. We set the timeline for this project as 1 year, with approximately 4 months for each phase of this project. In the first phase, each organization nominated representatives from various regions of the country to join these 2 expert groups based on their expertise and leadership within their respective organization. Then the group members participated in a very rigorous literature review over a span of 3 months, looking at various different types of articles and synthesizing the relevant literature on designated topics. The aim of phase 2 was then to reach consensus on a comprehensive list of statements on the screening of DDH and CP hip displacement, and finally the guidelines were framed by a core writing committee in phase 3. To achieve consensus on contentious issues, we use the Delphi approach. Named after the prophetic oracle of Delphi, this approach is a consensus-building exercise requiring iterative surveys and controlled feedback from a group of subject experts. I don't expect you to read this busy slide, but all I want to show you here is that for the DDH project, we finalized a list of 35 consensus statements that we eventually used to frame and develop the guidelines. These covered important decision-making topics such as the role of clinical examination, when to use ultrasounds and x-rays, when to refer a suspected case to the orthopedist for further management, and how to perform risk factor screening. Similarly, for the CP-HIP group, we finalized a list of 20 consensus statements after 2 rounds of the Delphi process. Here again, the themes ranged from which children should be surveilled and how frequently, the role of clinical examination and serial x-rays, when to refer the child to the orthopedist, and when to discharge the child from surveillance. So the conclusion of this consensus-building process resulted in these 2 comprehensive algorithms that I put up here. One for the screening of DDH and the other for hip displacement and CP. These resources are available as a free download from the POSI website and can be disseminated widely to everyone. If you'd like, you can scan the QR code on the screen. You can download this, takes you right to the POSI website. You can take this up, you can print it out, distribute it to your friends and colleagues, and basically it is unrestricted open access to the guidelines. So what is unique about these guidelines that we have developed? It's one of the, I think the most important USPs is that the guidelines have been designed to be relevant to the Indian context. It's made in India for India. It's also broad-based enough to remain applicable to the diversity of India's healthcare settings. The focus here is on surveillance rather than screening, emphasizing the concept of periodic examination rather than having the stress of diagnosing it at one single episode. For the DDH screening, we aligned it with the National Immunization Schedule, which is a brilliant initiative run by the government, which brings millions of children into the Well Baby clinics for immunization between birth to 5 years of age. Also considering the limited access that we have to good quality ultrasound and the interpretation of those results, we decided to use ultrasound only selectively and permitted X-rays instead to be used to screen for DDH at an earlier age than what is normally recommended. And for the CP group, we empowered not only orthopedic surgeons, but our allied healthcare workers like physiotherapists and occupational therapists to schedule regular clinical examinations and hip X-rays for children with CP so as to detect early hip displacement. The guidelines have been published in the Indian Pediatric Journal and are available as a free download on the POSI website as mentioned earlier. We now have moved into the final phase, which is actually the most crucial one, of knowledge translation and implementation using various social media and online tools, publications and presentations at various national and regional conferences such as these to allow for a widespread dissemination and adoption of the guidelines by various healthcare providers. Here are some of the graphics we developed to demonstrate the various clinical tests to diagnose DDH that would be helpful to pediatricians and neonatologists. Similarly, for the CP group, we developed some visual graphics demonstrating the correct X-ray technique, the identification of GMFCS levels, etc. I'm happy to say that these guidelines were formally launched at the POSI mid-year meeting that we held in July of this year, which was attended by representatives and office bearers of all the participating organizations. We had a roundtable format which encouraged a small group discussion surrounding the development of knowledge translation tools using the knowledge to action cycle and implementation strategies using the effort impact matrix. So as I wind up, I'd like to share some of the lessons that we learned and what advice could we pass on to future researchers, any of the youngsters or anyone else sitting in this audience who may want to embark on a similar journey for their respective subspecialties. I think the first thing is to involve all relevant stakeholders right from the beginning to enhance the buy-in. We had some thought initially whether just we as the orthopedic surgeons could develop the guidelines, but I'm sure if we did this and then gave it over to the pediatricians, it would have been completely trashed. It's important to understand what are the potential barriers that we face in building knowledge and awareness with our colleagues, because some things are so important to us may not even be on their radar at all. And that's what we realized right away with the pediatricians when it came to developing DDH guidelines. They had so many things going on in their careers and in their practice that musculoskeletal problems were not even considered. It's important to consider what your local existing healthcare system is because you need to develop context-specific pathways relevant to it. And we could have easily just taken those guidelines which were published and used in other countries and said, here we are, let's use it for India. But I don't think that's really the way to go. I think it's important to think globally, but act locally. Again, I think just a group of two people sitting together and saying these are the guidelines is not really a right way to do it. I think you must follow a scientific, multi-phased, evidence-based approach to developing guidelines. I think only scientific rigor will really stand the test of time. You must match your knowledge translation and implementation strategies to identify barriers. I think you must identify the local champions in each of these different organizations, find out who are the leaders within these organizations, use various types of educational outreach, use support of technology, and of course the role of the government, which will come into play at some point, because that's the absolute behemoth which will take this project forward. And I think once you develop guidelines, it's good to share. As I've shown you before, we have put this up as a free open access on our website. Anyone can download it. There is absolutely no copyright. And we're now trying to help other countries in the subcontinent who have similar healthcare issues, like Sri Lanka, Pakistan, and other countries, to develop guidelines based on what we already have. What else have we learned from this remarkable 2-year journey? We've learned not only to be efficient, but also effective in our approach. Shockingly, even as experts, we were compelled to accept the gaps in our own knowledge, which in turn enriched our deeper understanding of the subject. And finally, we realized that whatever the problems that may surround us, I think knowing is not enough and having good intentions is certainly not enough. We must be willing to get our hands dirty and get the job done. In conclusion, I would say that this was certainly not a solo effort. I'm fortunate to stand in front of you as a spokesperson for the entire group. I really must gratefully acknowledge the huge efforts and dedication shown by all the representatives of the various organizations whose names are listed up here, who shared their time and expertise in bringing this project to fruition. I would be certainly remiss if I failed to acknowledge the support and guidance provided by our international collaborators from Canada, led by our good friend Kishore Moolpuri and his research director, Emily Schaefer, and the funding support provided by the various foundations. And to you, my amazing audience who have sat through this talk of mine, I really thank you for your attention. Thank you.
Excellent oration of Young Surgeons Forum, delivered by a veteran. Thank you. So, let us have the honor and pleasure of giving you the certificate. Photographer, please. I remember about 30 years ago, where these two young gentlemen, Sangeet Gawale and Alarik, they came for the quiz contest of IOA, and they had won it 30 years ago. So, congratulations.